the session called Bronchology 1. And we'll start by the first speaker, and it's my pleasure to invite our famous Semra, our now Professor Semra is one of our colleagues from the Bronchology Society here and from Izmir in Turkey. And also, of course, she is the chair of Foreign Affairs Committee and president of the European Association for Bronchoscopy and Intervention Pulmonology. Professor Semra. Professor Semra will speak about real-time EBUS-TBNA in sarcoidosis and tuberculosis.
Thank you for this nice introduction. It's always a pleasure to be in Egypt among my friends. I won't say colleagues, I will say friends, because I have been in Egypt for the last maybe 6 years, so I should become an Egyptian citizen, I guess. Let's start my talk. Real-time EBUS-TBNA in sarcoidosis and tuberculosis. As you know, mediastinal lymphadenitis can be seen in many different benign and malignant diseases. My topic is sarcoidosis and tuberculosis, and EBUS-TBNA is used most of the time for mediastinal or hilar lymphadenopathy, and sarcoidosis and tuberculosis are two diseases that can cause this problem. Let's start with sarcoidosis diagnosis. As you all know, mediastinal lymph nodes and lung parenchyma are involved in 90% of cases. Diagnosis of sarcoidosis requires clinical picture, imaging, and non-caseating granulation altogether. We cannot say when we see caseating granulomatous, this is sarcoidosis. It should be a full clinical picture complementing each other. And there is no specific cytological and histological pattern in sarcoidosis that describes or diagnoses the disease, and it cannot be confirmed only by cytology and histology. Exclusion of other diseases with same cytology and cytological and histological pattern are required, and there is no uniformly accepted diagnostic algorithms. I won't go into detail regarding the diagnostic yields, but conventional bronchoscopic methods are used in sarcoidosis diagnosis. These are conventional transbronchial needle aspiration, transbronchial lung biopsy, endobronchial biopsy, and bronchoalveolar lavage. There are varying diagnostic results depending on the study group and the population of the study is done, and also different studies. But they range from, say, 40% to 90% between these diagnostic methods. EBUS-TBNA and conventional transbronchial needle aspiration, transbronchial biopsy, and endobronchial biopsy, let's compare them. EBUS-TBNA has a diagnostic yield that is significantly higher than conventional transbronchial needle aspiration and endobronchial biopsy. It is comparable in diagnostic yield to transbronchial biopsy, but is significantly increasing the diagnostic yield if it is combined with transbronchial biopsy. If you combine EBUS-TBNA with transbronchial biopsy, diagnostic yield is increased significantly. But this is not true when it's combined with endobronchial biopsy, and it is shown in a study by Gupta and colleagues in CHEST in 2014. In stage 2 sarcoidosis, transbronchial lung biopsy and EBUS-TBNA are comparable as shown in this table from a study by Nakajima and colleagues in 2009. In stage 1, of course, the diagnostic yield of EBUS-TBNA is higher than transbronchial lung biopsy as expected, but in stage 2, diagnostic yield of conventional transbronchial lung biopsy is comparable to EBUS-TBNA. This graph also shows the different diagnostic yields from conventional bronchoscopic methods to EBUS-TBNA and combining conventional methods with EBUS-TBNA. As you see, lowest yield is with endobronchial biopsy. Transbronchial biopsy has considerable yield, around 60–70%. Conventional TBNA is comparable to transbronchial biopsy, but EBUS-TBNA has higher diagnostic yield. But if you do first conventional methods, and then if there are negative results, do EBUS-TBNA in those negative cases, combination of conventional transbronchial needle aspiration with EBUS-TBNA gives you a high diagnostic yield. The same thing is true with EBUS-TBNA plus transbronchial biopsy. And of course, you can combine all conventional methods, and in negative cases, you can do EBUS-TBNA and get 90% or 100% diagnostic yield. Although EUS fine needle aspiration is not my topic today, I just want to briefly touch that issue and compare it with EBUS-TBNA. EBUS or EUS-guided fine needle aspiration yields in stage 1 higher than in stage 2 as expected because there is more lymphadenopathy. And EUS fine needle aspiration appears to have higher sensitivity and accuracy than EBUS-TBNA, but the difference is not statistically significant. Sensitivity and accuracy of EBUS and EUS fine needle aspiration significantly are higher than those of conventional methods, and these are shown in different studies in the literature. What if we combine EBUS-TBNA and EUS fine needle aspiration, or EBUS-TBNA plus ESSB fine needle aspiration, which is using EBUS bronchoscope in esophagus to do EUS fine needle aspiration? This combination provides wider access to mediastinum than either procedure because stations 4L, 5, 8, and 9 can be accessed by EUS fine needle aspiration. Stations 4R, 10, and 11 can be accessed better by EBUS-TBNA. In fact, EUS cannot access 10 and 11, and most of the time 4R cannot be accessed by EUS. And there is another factor, potentially, this combination potentially resolves many logistic difficulties by reducing cost, wait times for patients, and dependence on other specialties for diagnosis. We shouldn't forget the variability of results in EBUS-TBNA depends on the pretest probability of having sarcoidosis, or also prevalence of the disease in the study population, in your country population. So prevalence of the disease and the pretest probability of sarcoidosis also affecting the diagnostic yield of EBUS-TBNA. That is shown in different studies. So the diagnostic yield can range from 50% to 90%, and this factor explains this change. Diagnostic yields by needle gauges. Do the needle gauge, the thickness of the needle, affect the diagnostic yield of EBUS-TBNA or EUS fine needle aspiration? There are studies done, and it is shown that it does not significantly affect the diagnostic yield. Whether you use 21 gauge needle, 22 gauge needle, you can get comparable results. Maybe there is some difference, but it is not significantly different. The site and the number of lymph node stations and number of needle passes and procedures do not affect the diagnostic yield significantly. How many needle passes are good? 4 needle passes are recommended. Between 3 to 5 is okay. And this is shown by a study done by Wednesday-Session-5 and Alima. And you should get 3 to 6 samples that are sufficient. And after 4 needle passes, it is shown that the diagnostic yield is not increasing much. And there is a new needle, 19 gauge EBUS needle. There are a few studies done on it. It shows that it has higher diagnostic yield than cytology needle. The yield is about 93%, but we need more studies, comparative studies to say evidence-based results. Because it gets histology specimens, we will see. Let's talk about cytological specimens and cell blocks. Smears and cell blocks should be taken together and sent to pathology department to diagnose granulomatous inflammation. Smear or liquid-based cytology gives 54 to 98% diagnostic yield, cell blocks 45 to 100%, and each by itself solely is diagnostic in 20 to 33% of the cases. So please combine cytology specimens, smears or liquid-based specimens, together with cell blocks to get a diagnostic yield, which can be 87%. And in stage 1, it's higher. In stage 2, it's a little bit lower. What is the place of EBUS-TBNA or EUS fine needle aspiration or EBUS-TBNA plus EUS fine needle aspiration in sarcoidosis? Why don't we do only conventional transbronchial needle aspiration or conventional bronchoscopic methods? There can be two options. First option, to use EBUS or EUS after negative conventional bronchoscopy. Second option, to use EBUS, EUS, or the combination in experienced centers as an initial investigation tool when diagnosis of sarcoidosis is most likely, if you exclude malignancy, lymphoma, fungal infection. And future randomized controlled studies are required on EBUS-TBNA or EUS fine needle aspiration versus transbronchial biopsy, conventional transbronchial biopsy, to find optimal diagnostic strategy. And there's another study required on rows with conventional transbronchial needle aspiration or EBUS-TBNA or EUS fine needle aspiration. Let's come to tuberculosis. The role of EBUS-TBNA in diagnosis of tuberculosis is not so well established as in sarcoidosis because there are so many studies on EBUS and sarcoidosis, but not so many in TB. There are some studies, so the related literature is limited. In thoracic tuberculosis, we can have two different forms to use EBUS-TBNA, TB lymphadenitis or pulmonary tuberculosis that is adjacent to the airway. It can be tuberculoma or a mass-like lesion. That is rare, but can happen. So the overall sensitivity of EBUS-TBNA in intrathoracic tuberculosis is about 65 to 94%. Negative predictive value is unfortunately low, and it is varying in different studies. Accuracy can be considered high, 85 to 90%. We should always send our specimens to pathology and microbiology department when we are doing EBUS-TBNA for a suspected case of TB. Even in sarcoidosis, if the case is suspected of sarcoidosis, you should send your specimens to microbiology department for fungal infection, for TB too. Why? To differentiate the diseases. So in tuberculosis, EBUS-TBNA diagnostic yield is high, 82 to 86%, and it gives good microbiological yield. Overall, the microbiological yield is less than pathological yield, but is about 53%. Smears give you 80 to 27% yield, culture 80 to 47%. TB PCR of the specimen taken by EBUS-TBNA, 54%, and it can identify even drug-resistant tuberculosis. Here you see in the first case, AFP positive microbiological specimen, and in the other one, the cytological specimen showing, although it's not histological, it's a cytological specimen, but shows the granuloma with necrosis that can be diagnostic for tuberculosis. There is a very nice study done by Navani and colleagues and published in Thorax in 2011 showing that EBUS-TBNA was diagnostic in 94% of the patients. So pathological findings were consistent with TB in 86% of the cases. We shouldn't forget cultures and smears when the case is suspected of granulomatous inflammation and tuberculosis. If pretest suspicion exists for tuberculosis, specimens should be sent for dedicated microbiological analysis. And here there is a very interesting result. If the specimen is diagnostic or indicating TB, there are cases having culture positive, but in pathological specimens that are not diagnostic by pathology, even in those, if you send them to microbiology department, those pathology negative specimens can be positive in culture. So don't lose your specimens, send them to microbiology. Combining EBUS-TBNA with conventional bronchoscopic techniques, as in sarcoidosis, increases the diagnostic yield in TB lymphadenitis from 18% to 80%. However, there's an important point. When we get a pathological diagnosis like granulomatous inflammation, whether it has necrosis or not, we are not diagnosing exactly. The diagnosis should include the clinical picture, imaging features, laboratory, plus pathology and microbiology all together, because we may be misled by just granulomatous inflammation. So EBUS-TBNA can say to you granulomatous inflammation with necrosis, without necrosis, but this does not differentiate absolutely. Distinction of TB from sarcoidosis depends upon correlating cytological, microbiological, clinical, and radiological data in large series in TB endemic regions. There are some endosonographic features of benign lymphadenopathy. I'll just briefly touch on it. Round shape, distinct margin, heterogeneous appearance, echogenicity, coagulation, necrosis. If all these features altogether are absent, it's said to be that they can be benign. Or another study says short axis, more than 1 centimeter, well-demarcated nodal margins, absence of central hilar structure, multiple clustering, non-hilar perfusion, isoechoic appearance, and granular appearance may indicate benign lymphadenitis. However, we cannot differentiate by just appearance. Maybe they are helpful, but we need tissue. And sarcoidosis versus tuberculosis on EBUS or EOS, the ultrasonographic appearance. For example, when there is coagulation necrosis, it may mean that it is tuberculosis. When there is heterogeneous extratexture, it can be more like sarcoidosis, but we cannot depend on these ultrasonographic images. So tissue is the issue. The real diagnosis comes with tissue, but you have to combine it with the overall picture. So we can get diagnosis by cytology if your cytopathologist is good in TB and sarcoidosis, but be careful, it can be sarcoid reaction. Not everything is granulomatous inflammation due to sarcoidosis, tuberculosis. It can be a sarcoid reaction to something. So there are different pictures, cytological pictures, histological pictures. This schema is good. When you get granuloma, keep in mind that there can be a coexistent disease besides sarcoidosis or tuberculosis. It can be past sarcoidosis, not active. It can be a sarcoid reaction to a treatment, or there can be a malignant disease beside that granulomatous inflammation. Some malignant diseases such as lymphoma, lung cancer, maybe others, can cause sarcoid reaction, but it is not sarcoidosis. So be careful when you are interpreting. Cytopathologist is important. Her or his experience, expertise, technique, what she uses, and quality of the sample are of course important, but ROSE does not increase the diagnostic yield significantly. It has some effect. The real effect is there are less needle passes when you use ROSE, less inadequate needle passes. It is beneficial, but if it's not there, you don't get so sad. So there should be a clinician-cytopathologist communication, algorithmic approach to diagnosis, on-site adequacy criteria, and then when you combine these, your diagnostic yield is improved. There is a new needle, but used in only studies. It's called needle with forceps. They have, at the end of the catheter, they have the needle plus forceps. They first go with the needle, make a hole, and then put the forceps inside and get histological tissue. The results are good, but it's not in routine use yet. We will see. More studies are required. EBUS TBNA and EOS fine needle aspiration are both safe procedures if they are done appropriately and if they are done by good hands, with experienced hands. The complication rate is less than 1. I have one more slide. Complication rate is less than 1.5 or 2% in both procedures. I have finished. Okay, I have no slides. Okay, thank you for your patience.
Thanks, Professor Semra, for the illustrative lecture. First of all, I thank the Egyptian Bronchology Society for inviting me, and special thanks to Professor Tariq Safwat and Professor Adel Khattab. It's a great honor for me to co-share this session with Professor Ashraf Hatem. And now we introduce Professor Hassan Kami to give a lecture about the role of EPAS in mediastinal staging of lung cancer. Professor Hassan.
I'd like to thank the organizing committee for inviting me to give this presentation. Really a pleasure being here and working with the workshop yesterday with Dr. Ashraf. It was a real pleasure. I hope you'll enjoy this talk that's a bit of an update on the role of endobronchial ultrasound in the staging of lung cancer, which complement the talk of Dr. Semra before me. So I'll be talking about the mediastinal staging of lung cancer in general first, and then we'll talk about the data on the role of EBUS. So everybody in the room knows that lung cancer is the #1 killer worldwide. It was estimated, and that's both in male and female. It was estimated to kill 1.2 million people in 2008, and data from the US showed that it was responsible for 160,000 deaths. It's not only the #1 killer, but it's also responsible for more deaths than the 4th leading cancers after that: colon, breast, pancreas, and prostate. So more death than the next leading 4 cancers combined. Now, staging is probably the most important step in the management of this deadly disease. It determines the prognosis and determines the therapy, so it's very important to be done accurately. And this is the TNM stage there that's still used. Lymph node stage specifically is the most important determinant of therapy in the absence of metastasis. In fact, the 5-year survival significantly changes depending on the lymph node stage, between 55 down to 5%, go from N0 to N3. To be able to stage the lymph nodes adequately, we use a map originally developed by Mountain and Dressler, and this is the classification here that I'm not going to go over in details, but it was most recently updated by the International Association for the Study of Lung Cancer 2013. According to the most recent classification, we continue to classify the N stage as N0, N1, N2, N3. N0 is no lymph nodes, N1 is the ipsilateral hilar or peribronchial, which is interlobar, lobar, and peribronchial. And N2 is when you're dealing with an ipsilateral mediastinal lymph node or a subcarinal. Once you go to the contralateral side, that's N3. Or if you go to the station 1, the supraclavicular and scalene lymph nodes. Now, in the most recent revision of the classification, there was a proposition to have subclassification that takes into account whether you have one or more stations and whether there's skip lesions. But this was not adopted in the classification, so it's just a proposition. We're probably going to be adopted with the classification afterwards. This table shows you the effect of the end stage on the overall stage and therapy of the patient. So you can see that if you have an N3 disease in blue, you're automatically into 3B or the new 3C stage. And this would preclude surgery as an intervention. So just by knowing that a patient has N3, you're directly precluding surgery, and you're having basically a chemotherapy radiation kind of modality. With N2, you get to a 3A in T1 and T2, and maybe you could have a neoadjuvant, then a surgery if you have a lobectomy, and maybe not more than one station. And if you have an N2 with T3 and T4, again, you're in 3B and you're precluding surgery. So the N, you can see how the N makes a big difference. And even in N1, if you have a, sorry, I moved here. So even with T3, T4, if you have an N1, you're in 3A also. So how do you stage the patient? The first test is usually the CT, okay? And based on that, the radiologist would classify the lymph node as positive or negative based if it's a sub-centimeter or more than a centimeter. And if it's less than a centimeter, then it's typically negative. However, you can miss up to 20% of metastasis to the lymph node with this classification. So not very accurate. And that led to sensitivity of about only 51% and specificity of 85% with just CT. Now, with CT PET, of course, our ability to detect metastasis improved by detecting activity in small lymph nodes that are less than a centimeter, but their sensitivity is still up to 74%, and there's about 15% false positive, so your specificity is 85%. So you can't believe the PET scan all the time. You can miss disease with negative PET scan, and you can overstage people with PET scan. So what do the guidelines tell us? Okay, when do we have to confirm the staging invasively? There's most of the situations, actually, there's only 2 exceptions, and I'll go over them. So most of the time, so if you have a discrete mediastinal lymph node enlargement, more than a centimeter, with or without PET scan uptake in the mediastinum, you still need to confirm it. Okay, so any lymph node that's enlarged, you need to confirm it by invasive. Okay, and we'll talk about how to confirm it. If you have PET activity in a mediastinal lymph node, any size, so even if you can't see it much on the CT, if you have PET activity, you also have to confirm it. And that's what the guideline conclusion with a high degree of certainty, grade 1C. And then there's this situation where if you have a central tumor or an N1 lymph node, okay, even with a negative mediastinum, even with a negative PET and CT, so if both these conditions are negative, but if you have an N1 disease or if you have a central tumor, not a peripheral stage 1 tumor, you still need to do an invasive staging before you go to surgery. That's the recommendation. And this is actually considered to be intermediate risk for malignancy. So how do you stage it? What's the preferred modality by the guidelines? It's EBUS, FNO, or US, so endosonography. So based on the guidelines, they recommend endosonography over surgery for staging in both these conditions with high suspicions, be it a discrete enlargement of the lymph node or a PET positive lymph node, and the intermediate situation where the mediastinum is negative by imaging, but you have an N1 disease or you have a central lesion. So when do you not stage the mediastinum? I told you there's only 2 exceptions. If you have a peripheral stage 1 disease, so not central, with a negative imaging. So the CT, the PET should be negative, no N1 disease, and the tumor should be peripheral, not central. And in that situation, you can proceed straight to surgery with no invasive staging. And the other situation, if the tumor is actually invading the mediastinum. So if there's direct extension in the mediastinum, then you don't need to stage it. It's considered to be involvement of the station where the tumor is invading. So what are the modalities of staging invasively? The initial modality was surgical mediastinoscopy before the development of the endosonography. We have cervical mediastinoscopy that allows us to access station 1 to 4 lymph nodes and the anterior part of the subcarinal, station 7. And then for the station 5, 6, the pre-aortic, para-aortic, then you need the anterior mediastinostomy, which is the Chamberlain procedure. It's more challenging. So both of these procedures are invasive. They require general anesthesia, and they also have limitation. They're unable to assess stations 8, 9, 10, and 11, and posterior 7. So the paraesophageal, the pulmonary ligament, lymph nodes, and the peribronchial lymph node, you can't assess them. You're going to need to do VATS for that. For many years, we had to deal with blind TBNA with the Wang technique, and of course, it's less invasive than surgery. That's all we had, but the problem with that is the sensitivity is quite low, 39% in published literature, and when you go only for the subcarinal, if you only analyze the subcarinal, then your sensitivity is up to 45%. So not quite helpful in all situations. Then came the EOS FNA, and it showed good sensitivity. It allowed us to sample the subcarinal, which is common, and mostly the left-sided mediastinal lymph node, in addition to the paraesophageal and the pulmonary ligament. It also had a significant advantage when the fellow gastroenterologists started venturing and they started biopsying adrenal masses. So now you can diagnose metastasis, subdiaphragmatic metastasis. You can go to the celiac axis and even liver metastasis. So you can diagnose the M stage in these locations with EUS, and you can reliably sample some, but not all. So there was, of course, quite an interest in trying to replicate the same technology in the bronchus, since you have more access to lymph nodes, and with EBUS, you were able to assess most of the mediastinal 2, 4 lymph nodes, 3P even posteriorly, subcarinal, and the hilar and peribronchial lymph nodes. The stations that you cannot access with the EBUS are the paraesophageal pulmonary ligaments, and of course the lymph nodes that are on the other sides of the great vessel of the aorta, the station 5 and 6. So if this is just a comparison of what EUS and EBUS allows us to sample, they're quite complementary. The EUS can sample the left-sided mediastinal, subcarinal anterior, and the paraesophageal pulmonary ligament. EBUS can give us an access to all the peribronchial and peritracheal lymph nodes, and the esophageal and the pulmonary ligament could not be accessed by EBUS unless you put the scope in the esophagus, which there's quite some reports on that. So the overall clinical application of EBUS is to lymph node staging, but also many times you can diagnose and stage in the same procedure in up to 20% of the situation in some of the reported literature. Of course, it can also give us alternate diagnosis for such as sarcoid and lymphoma, goiter, and TB sometimes. So what are the published data that support the use of EBUS? The first study came out of Japan in 2004 and included 70 patients for diagnosis of mediastinal and hilar lymphadenopathy, and it showed a really good sensitivity of 95% and a specificity of 100%. The findings were replicated in a larger sample from Europe with 500 participants and showed similar good sensitivity and specificity. Now, specifically for staging lung cancer, there was this study also of EBUS TBNA in 100 patients, and it also performed very well with a high sensitivity of 94% and a very good specificity and negative predictive value. And in 20 of those patients, so about 20%, they were able to diagnose and stage in one procedure. As a result, they were able to avoid 29 mediastinoscopies, 8 thoracotomies, and 4 VATs, which was quite helpful. Based on that, the EU gave its mark in 2004, and the FDA approved the use of EBUS in 2006. And over time, the experience with it and the published data grew, and we have quite a bit of impressive data to support its use. So how does it compare to CT and PET? In this study, they looked at how the accuracy of all procedures, and EBUS TBNA outperformed PET scan and CT quite significantly with a 92% sensitivity, 100% specificity compared to much lower sensitivity for CT of 76% and specificity of 5%. Now, with the PET-CT, the combined PET-CT, also the data supporting EBUS is superior. You've got about, EBUS TBNA, the sensitivity is 90% versus 70%, and the specificity is superior. It seems EBUS outperformed PET-CT specifically and most commonly in adeno-CA, which tend to be less metabolically active. So most of the cases where PET-CT was negative turned out to be adeno-CA. And then EBUS was also tested in specific situations. So for example, in people who have positive mediastinum by PET, so have positive mediastinal adenopathy by PET, in this study you have 100 patients, and they used EBUS plus surgical sampling when EBUS was negative, which is actually the recommendation is always to go for when there's a high suspicion. Despite EBUS being negative, you have to go to surgical intervention to confirm that. And PET was able to diagnose lymph node metastasis in 58% of the cases. So many patients had the PET positive that turned out not to be involved by malignancy by EBUS. And the sensitivity was quite high at 95%. What about the surprisingly radiologically normal mediastinum? I told you that the guidelines recommend that we sample the radiologically normal mediastinum. And this is based on a study similar to this, where they had 100 patients with a negative CT. So basically the lymph node size is less than a centimeter. The average diameter was 0.8 centimeter. And malignancy was detected in 19 patients who had, so about 20% of the sample had a positive EBUS despite having a CT that's negative. So these patients would have missed a higher stage. They were understaged clinically. And even in the subset of patients who have a PET-CT negative, so both the PET and the CT is negative, we have a similar size, 97 patients with non-small cell lung CA, and they did the EBUS, and they found that there were 8 patients who had a negative PET-CT and still had a positive evidence of metastasis by EBUS. And again, if you look at the series, most of these patients had adeno-CA except for one who had squamous. So again, EBUS is superior specifically in these categories. So adeno-CA and negative PET-CT, you don't trust the negative PET and CT. So I'm not going to review all the literature, but this is just to show you that we have now a good body of evidence summarized here in the most recent guidelines with more than 2,700 patients with a median sensitivity of 89%, which support the use of EBUS. So can we still say that mediastinoscopy is the gold standard? So this is a valid question based on these data. And to prove that, they actually went head-to-head with EBUS versus mediastinoscopy and showed that they actually had similar, they performed very similarly with less complication with EBUS naturally. So about 80% for both and a negative predictive value of 90%. So what about EBUS versus EUS, which is better? We said we have to think about them really more like complementary than head-to-head. But in this study, they got patients who underwent sequentially a Wang blinded biopsy, then EBUS and EUS FNA, and they showed that the TBNA didn't perform very well in when blind, so sensitivity of 36%, and again 45% if you're only counting the subcarinal. And that EUS and FNA EBUS performed similarly with about 70%, but when you combine them, your accuracy improves significantly, so 93%. So based on that, actually another randomized controlled trial was designed where people were randomized to either mediastinoscopy or endosonography with mediastinoscopy afterwards if the endosonography is negative. And with that, the arm that used endosonography before mediastinoscopy had a significantly better sensitivity of 94% versus 79% sensitivity for the mediastinoscopy. So we think of the mediastinoscopy of the gold standard, but not really. The guidelines now recommend endosonography first based on randomized control trial data from this study, and then you would use a mediastinoscopy if your endosonography is negative. And in this study, when you just compare the results of the endosonography versus mediastinoscopy without accounting for the surgery that happens afterwards in the endosonography, if the lesion is negative, you find that the endosonography is also superior with a sensitivity of 85% compared to 79% for mediastinoscopy, and the complication rate significantly better. So in summary, staging of mediastinal lymph node is crucial for management of lung cancer. The PET-CT are insufficient. We can't rely on this clinical and radiographic stage to deny or send people to surgery. And the guidelines recommend invasive staging for confirmation in most cases, except if it's really just an isolated lesion with negative PET-CT and a negative N1 lymph nodes, or if there's gross involvement of the mediastinum. The advantages of EBUS is that it's a safe procedure. There's an ability to diagnose and stage with a survey of the airway. You cannot survey the airway pre-op, and it's highly sensitive compared to mediastinoscopy. The difficulties is the steep learning curve, the very important reliable cytologist. If you don't have a cytologist that you can rely on, then your yield is not going to be as good as these expert centers. And negative results continue to be challenging, so you need a mediastinoscopy if your endosonography is negative. And with that, I stop and I can take questions. 15 seconds to go.
Okay. Thank you very much, Dr. Hassan, for your very illustrative talk. And as a token of appreciation from the Egyptian Scientific Society for your interesting talk, and for you coming for our conference, Professor Tariq Safwat is presenting for you the shield of the Bronchology Society. Now, last but not least, we have Dr. Grigoros Stratokos from Greece, and he will speak about management of malignant central airways obstruction, indications, techniques, and pitfall.
Okay, thank you. Thank you, Mr. Chairman, dear colleagues. Thank you for staying up to this time. And I will quickly go through my subject, which is practically how we can treat a patient with an obstructed central airway. Well, the image is something like that. It's everyday patients. There are people coming to our offices or to our hospitals with this problem. And most doctors feel awkward, feel unable to treat a patient gasping for air because he has not only cancer, it's not the cancer he suffered from, it's the breathlessness. And the distance from this X-ray and this endoscopy to this is only 1 hour. After 1 hour of intervention, we can reveal the breathlessness of the patient. We can take out of the bronchus the obstructing tumor and re-establish the chest X-ray and the patency of the airway. But, okay, we could stop this talk here saying it is feasible, it can be done. I will explain you later the ways it can be done. But the question is it worth it? Some of you may say that this is a lung cancer patient, it is an inoperable case. Why bother treating this case, and why not leave him die in peace? Well, it's very current, first of all. It's very frequent that we see lung cancer patients with central airway obstruction, and this causes a lot of suffering. You cannot avoid seeing that. Only 20 to 30% of the cases of lung cancer, which is so frequent, will develop central airway complications, and to that you should add also tumors, extrathoracic tumors invading lungs, like uterus, like ovarian cancer, like colon cancer, like renal cancer, which can invade and metastase to the lungs and to the airways. So it's something very, very frequent, and in most of the cases, surgery is unable to help the patient. So interventional bronchoscopies, we are the only ones to be able to help these people. And I'm coming back to the question, is it worth it? First of all, we don't know exactly, because there are not many studies studying this question. Why? Because it is unethical to have two groups and compare a group which you will treat and a group in which you will deny treatment. It's unethical to leave patients without treatment, since you can do that. So there are not many studies on that. This is a classical study, you can see it in every congress, showing the difference between the people in which treatment was possible against the group in which it was not possible. I'm trying, okay, sorry. And the difference is 4 months of survival, which may not look too big, but it is the mean difference of oncological treatments most oncologists give. So it may be important. We did a study in our department in Athens, because we had not established yet the fame of interventional bronchoscopy in Greece, so a lot of people did not get reference to interventional units, and a lot of people did not get counseling to accept interventional bronchoscopy treatment. So we had a group of patients with lung cancer and central airway involvement who did not accept to sign the consent for interventional treatment, or who did not have a reference to us. So we studied them against the group of people we treated. And what we saw, it was a huge difference in survival. Our patients had survival of 10 plus minus 9 months versus 4 plus minus 3 months for the non-treated group. And it was not only the survival which was different, the survival which was different, but it was also the quality of life. I don't have a pointer for a reason, it doesn't work. Doesn't work. Okay. Maybe you can give him something else. So the survival was different, but it's also the dyspnea which was different, the quality of life was different, and the people could have other treatments. This is the most important, that revealing the obstruction, you can lead the patient to oncology unit and take other treatments. So you give them the opportunity to take some advantage from oncological treatments. This is a study which came up last year. It's a Chinese study with many hundreds of patients. And they compared, in the first scheme, they compared the group of patients without central airway involvement and with central airway involvement. And you see the difference. At that time, when the comparison was done, they did not have an interventional bronchoscopy facility in their hospital. And after a year, 2007, I think, they had the interventional bronchoscopy facility in their hospital, and you can see the difference. There was no discrepancy between people who had central airway obstruction versus those who did not have central airway obstruction. They were both non-operable lung cancer patients, but the difference in the beginning, it was because the one group had central airway obstruction. And after the interventional bronchoscopy was established in the hospital, the difference was eliminated. So that's the meaning, that we can make the difference to patients who have bad prognosis because of central airway obstruction. Okay, how can that be done? There is an instrument, the rigid bronchoscope, and this is the instrument par excellence, like the French would say. It's the instrument, the most advantageous instrument we can use. Of course, together with our flexible scope. We can never separate. When we go in the operating room with the rigid, we have the flexible by our side. This is all the times. Which techniques? Mechanical. First of all, we have the mechanical debulking with the shaft of the scope. We can take this tumor with a forceps or with the aspiration tube, like you see here. Simple mechanical pulling out of the tumor and revealing of the obstruction. Okay, through this rigid scope, of course. Electrocautery. We can avoid bleeding, or we can destroy the lung, the tissue, the pathological tissue, the abnormal tissue with contact electrocautery. We just cauterize or coagulate or cut the tumor, and then we can dissect it with our forceps or with the rigid scope or with the flexible scope. Argon plasma coagulation, which is again electrocautery from a distance. We are not touching the tumor, we are injecting electrical current through the argon gas, and so we can coagulate a large area of the mucosa. Or cryotherapy, cryodebulking. We have a cryoprobe and we stick the cryoprobe on the tumor like we stick our finger on the ice cube. Have you touched the ice cubes with the bare fingers? It gets stuck on the finger. The same way this cryoprobe sticks on the tumor, and you can reveal huge pieces of tumor out of the bronchus. And if you waited to do that with a forceps, you should work more than 4 or 5 hours. With this cryoprobe, you can do that in a few minutes. Okay. Of course, we judge every time according to the disease. If the lesion is intraluminal here in the first, unfortunately this doesn't work so I cannot show you, but in the first scheme you see the intraluminal lesion. In that case we just remove the tumor or we destroy the tumor with laser or with cautery or whatever. If we have an extrinsic compression, we cannot use anything to destroy a tumor. There is no tumor to destroy. There is compression from the outside. So the only thing we can do is dilate and put in a stent. Or if it's mixed, we do both. Electrocautery again comes with many instruments for the flexible scope, with probes, with knives, with snares, with forceps, of course. And the snare is a very nice instrument. You see here how you can cut and move out of the bronchus huge or tiny tumors all together, cutting them from their neck. When you have a pendulating tumor which has a small neck connecting him with the bronchial wall, you can cut it all together by catching it from the neck and then coagulate and pull it out of the scope without a drop of blood. You see here this case of an hamartoma taken out by this snare. Okay. I just wanted to show you how it's cut like that. It comes all together out. Okay. The argon plasma coagulation, I said already, it's jet of argon, ionized argon gas, which closes the circuit with the patient and can produce very, very effective coagulation on the mucosa. Usually it's not very effective for destroying the tumor in depth because it doesn't go in depth, it stays superficially, but it is attracted by the blood because blood has less resistance to the electrical current, and once the lesion, it has been cicatrized, it has been dried, then the resistance to the electric current returns to normal, so the argon plasma does not go in depth. So it's very, very safe. It's the safest way to treat a bronchial hemorrhage. Both modalities of electrocautery come in the same generator, so you can have one instrument and do both electrocautery. As you noticed, I didn't talk about laser. Why? Laser is the father or the mother of modalities of cutting and destroying the tissue in the lung. And most of the pioneers, like Dumont, this film is from Dumont, introduced us all in this modality. But it has some characteristics. First of all, nowadays we don't need laser so much. We use it less and less as time goes by because we have electrocautery, we have argon plasma, we have cryotherapy. And there are not many advantages of laser against this. It is more expensive, it's more dangerous because it goes very much in depth. It's very effective, it's very quick, but it's equally dangerous and it needs a lot of experience to use it. And first of all, it needs being sure that the axis of the bronchus is where you see it, because you know when the bronchus is obstructed, the anatomy changes, and what you think it is in front of you or downward can be anterior, and then you can find yourself in the mediastinum. So it's a very dangerous technique, and I think most people now don't use it anymore. Cryotherapy, I explained. It's very effective, and of course it can be used together chemotherapy and radiotherapy because it looks like it sensitizes the tumor. Cryodebulking is now a technique which is readily accepted, and you can reveal obstruction and take out huge pieces of casts from the bronchi. And you can see this case. For example, we have a huge tumor on the left main bronchus. Diagnosis was not set because the doctors who did bronchoscopy were taking pieces of necrotic tissue and were not able to take the diagnosis because they could not remove the tumor. The only way to remove this tumor is with this cryoprobe, and that can be done equally with flexible and with rigid. Of course, with flexible it is more dangerous because you have to be able to go quickly inside and see if there is any bleeding to treat. You see, huge pieces of tissue can be removed at once with this cryoprobe. And of course, blood clots equally. You can reveal obstruction and respiratory insufficiency in patients in the ICU who have been in mechanical ventilation because of obstruction, because of bleeding, or because of tumors. You can reveal them, and you can win from mechanical ventilation just with one movement of cryotherapy. There are a lot of studies, I don't have time to present them all, showing that it is effective and safe. However, you have to treat the hemoptysis or the bleeding, which comes after removing the tumor. So that's why most authors suggest that you do that under intubation or rigid bronchoscopy. So either you work with rigid bronchoscope or you intubate the patient with a laryngeal tube, tracheal tube, and then you work through that. You can have some complications, but they're rare, and most of the time it's very safe, and in my experience it's extremely safe and effective. So I'm going to the last piece of information on this subject, and I would like to ask if you know who's this guy. Do you know? Who knows? Well, this guy is Charles Stent, and it's one of the very lucky persons who had their name being not only a noun, but also a verb. We stent people, we stent airways, we put in stents. So he's a dentist of 19th century who first found the casts for the teeth when they were removed. He was putting in material in the vacant space in order to keep the denture correct. So after him, all the prostheses were named, and now we have a lot of them. We can use them either with rigid or a flexible scope, and we have either silicone or metal prosthesis covered with polyurethane. Most studies have studied rigid stent, Dumont stents, silicone stents. They're very flexible stents. We can have them in various shapes and in various sizes. We can have it straight or bifurcated. We can customize them according to the abnormality of the bronchi. I think it is the most flexible and easy to use stent. And you see here you can treat very hard cases with invasion of the lower trachea, invasion of the carina, people who are hopeless otherwise. Now they can breathe easily and they can survive for many months. They can take the treatment, they can take the radiation, they can take chemotherapy, which they were unable to have before our intervention. So that's the meaning. And of course we have to size correct the stents, and we can use some metal stents which have the advantage of being put also with a flexible scope, but there is a lot of questions in the literature. Why is this an advantage? Why it is an advantage to put it in with the flexible scope, since you have to use the rigid scope to remove it? Even if we put these stents with the flexible scope, we have to remove them with the rigid when they are complicated. So that does not mean that it is better to use the flexible scope. In emergency cases, when it is impossible to use the rigid, you can take your flexible and you can put them in. It can be done. But if it gets complicated, you have to know how to remove it with the rigid scope, because this is important. And so this is, I think, my last slide, and shows an intervention. You see again the right main bronchus obstruction. And first of all, in that case, the most important thing you have to have in mind is to find the way to the periphery. First, you have the way. If the periphery is obstructed, there is no reason to dig in the cancer. We remove cancers which are centrally located, and beyond the obstruction, the airway is normal. So you have to find the way to the periphery. You have to create a pathway, and then you can dilate it and you can remove the tumor. Take care not to enter the mediastinum while digging in this cancer. So when you see this pus coming out, you know that there is patent airway beneath, because pus is accumulated in patent airways. If it was tumor all around the periphery, we didn't have pus. We wouldn't have pus. So we remove the pus, and then with the shaft of the scope, you can dig and you can remove the tumor like we remove it with the tire-bouchon from a bottle. And then you can have this tumor with the forceps removed, and you can put in a stent. If it is needed, most colleagues, thank you, most colleagues send us patients for stent placement. They say, take this patient and put him a stent because you're interventionist. The minority of the cases need a stent. Don't put stents without a reason. We are putting less and less stents as time goes by, because we have understood that stents are not good solutions and have a lot of complications. So if they are not needed, we don't put them. We have a new age of stents. We have drug-eluting stents. We wrote a review last year on that. We have stents that can give cisplatin, paclitaxel, mitomycin, fluorouracil, or other drugs for cancers. And last month we had also a radioactive stent which can deliver radiation to the airways. So that keeps changing. I'm sure that in next decade we will have a lot of active stents, either with radiation or with chemotherapy. And for all of this, we need education. We need continual medical education. And I would like to tell you that in Athens we are creating a systematic effort to train people in interventional pulmonology. And this year we will have the 8th ERS school on interventional bronchoscopy, to which you're all invited. It will be next October. With that, I will thank you one more for the invitation, and I wish you every success.
Thank you very much, Dr. Grigoros, for this very interesting talk. And for the sake of time, I'll announce this session to be closed, and I call for the next session.